I hope you're able to see my slides. Okay. So this is going to be more of a kind of uh, a a rebirth or a revision lecture for because most of the things have already been taken or that will be taken in details in subsequent lectures. So this is going to be in general the management of ECMO. So if you want to run a successful ECMO program, you have to have a right candidate. You should start at right time. It should be right weapon. So the mode of ECMO, VB, VA versus VAV. It should be the right way. You should have clear goal in your mind. You should have your strategy well defined before. And it's not that you know only your strategy. The entire team should be knowing that this is the strategy which you are going to follow. And it's going to be a right team. That is what is important. And the most important is the safe ECMO practice. And that is what is our medical dictum is also. We do not want to do harm. Whatever you do, but don't harm the patients. So that is a safe ECMO practice is equally important. So what I'm going to talk about is the principle of management, the goal of management, the management during initiation, management during ECMO run, and the management of complications. So these are the two important slides which you should understand. And these are the two basic principles when you are managing the patients on ECMO. One is balancing the adequacy and safety. And that is what the most important is. Throughout your ECMO run, you have to always see that what is an adequacy and what is the safety. Many a times it is as thin rope as this, and it's just like you have to walk on this rope. Uh, Many a times there's a very little difference in that, and then you have to take a decision what is going to be better for that. For an example, I can give you if the patient saturation, in spite of being on 6 liters of flow or 7 liters of flow, saturation remains 70. Whether you want to treat that 70 saturation or no, that becomes one question. If you want to treat the situations, would you like to go up on the flow, then 7 liters? That is the second question. Would you like to increase the hemoglobin? That is the third question. Would you like to induce hypothermia? That is the fourth question. Would you like to do VECMO? That is the fifth question. So there are multiple options you have. So you have to decide whether it is adequate or no. Suppose the saturation 70 is adequate, you don't want to do anything. But suppose that you find it's not adequate, then you have to do which is the safest mode of getting the adequacy. Whether going up on the ECMO flow is going to be safer, whether going up on the hemoglobin is going to be safer, whether inducing hypothermia is going to be safer, or whether converting to VECMO is going to be safer. So you have to decide which is going to be safe. So always it is a ECMO is entire run ECMO is a balancing of adequacy and safety. And you should be strong enough and you should be persistent enough to struggle to the last chance. Many a times it happens that you feel that a patient is gone out of your hand, and then you struggle that time and you can still get the patient out. So you have to have that zeal in your mind that yes, you want to get the patient out from that. Don't give up your weapons in between. These are the two basic principles. What is the goal of ECMO? Goal of ECMO is keep patient alive. Okay, the organ is going to recover, keep patients alive. That is what is the basic, and especially in VV ECMO, in respiratory ECMO, because these runs are going to be long run. So your intention is keep patient alive by adequately and safely supporting the patient. So you can keep the patient alive, and at the same time you have to speed up the recovery of the organs. Not only in the lungs, because lungs I said because it's going to take a long time, but you have to try to speed up the recovery of the organs. So you have to work at both the levels, give adequate and safe support, but at the same time, try to get the organs recovery as fast as possible. So do whatever you can do for an organ recovery. For an example, in case of lungs, you have to prevent ongoing damage. You think about adjuvant therapies, physiotherapy, mobilization, if required bronchoscopy, so you get rid of suction. And in case of heart, cardiac condition, you think about underlying cause and treat underlying cause. So you revascularize the patient. It's not just you put the patient on ECMO in cardiogenic shock with the patient going ischemic heart disease. If you don't revascularize, they are not going to recover. So you have to think about revascularizing this patient. Now, what will be the best time of revascularization? That depends from patient to patient or from time to time in each case. So that is different story. But you have to think about treating the underlying cause and try to get it back to the normal. So the management of initiation of ECMO, how you are going to manage the initiation of ECMO. So you have to have proper preparation, the team's preparation, the relatives preparation, the circuit preparation, the patient preparation, and that preparation has to be kept with an anticipation that these are the problems that can come when you are going to initiate ECMO, and you should be ready with their solutions. You have to go in sequence by checklist. So you should have all checklists ready. Everybody should know of what is their work. The team should be trained properly. Perfusionist knows that the one who is going to prime the circuit, he knows that he has to arrange for the blood. It should not happen that we have started ECMO and now hemoglobin has dropped down to 5 and we don't have arranged blood. So that has to be, all team training has to be most important. Good and continuation of documentation is important. Always keep the backup and emergency plan ready, and communication with the family is going to be the first. So initiation of ECMO, we start, as I told you yesterday also, you start with a flow of 20 ml per kg per minute and go to the full flow over 20 to 30 minutes. And the exception here is only ECPR, where you can go directly up on the flow. Why you don't want to go up on the flow, as I told you yesterday, is it will increase the risk of cardiac stunning, and rapid correction of hypoxia or hypercapnia can lead to neurological issues. So you don't want to correct it rapidly, because that causes a reperfusion injury and that creates the problems. Always when you go up on the flow, come back to the rest settings, rest ventilator setting and rest inotropic settings. So you have to get rid of your inotropes, or you have to come down to minimum inotropes, get rid of ventilator. That is what is your aim is. Your aim is not to just get the saturation, not to get the uh, uh, tissue perfusion, not to get the mean arterial pressure. Your aim is to give rest to the heart and lungs. So you have to always situate you come down to the ventilator and inotropic scores. Okay. And sweep gas start with the 0.5:1 and can go up to 1.5:1. So ECMO is everything. In ECMO, everything is flow. Okay. You have nothing but then you don't have nothing else than to do flow. So you have to target your flow. What should be the target of the flow? The target of the flow is, number one, it should able to give rest to the organs. That is what is your target of the flow. What is the goal is to rest? Goal is to get rest of the organs. What is the another goal is to get adequate support. So you have to get adequate support, okay? But at the same time, keep the safety in mind. So to keep the safety in mind, get an adequate support. Once you are on adequate support, come down on ventilator settings, come down on inotropic scores. And then when suppose that drops the saturation, go back on the ECMO support and give rest to the organs. That is what is most important is. How will you assess the adequacy of support? On VA ECMO by tissue perfusion, and in VA ECMO by saturations. Saturation of 80 to 95 is always acceptable. And how will you track for safety of support? VA ECMO by pulse pressure, and VV ECMO is minimum recirculation with your maximum flow. So that should be your criteria. Now, what are the issues that can come when you are going to initiate ECMO, and how will you manage this? The first issue that comes is you initiated ECMO, VV ECMO, or we initiated V ECMO, and you don't see any change. You don't see this saturation improving, and saturation is still remaining there. In spite of you have gone up to 2 liters, 3 liters of flow, there's no change in saturations. The commonest cause is there's something wrong with your oxygenation. So you look at the tube color, both the right side and the left side tube, the drainage and the return tube colors. If both are same, in VV ECMO, it means recirculation. If both are dark, that means you have somebody has forgot to connect the sweep gas or oxygen to the connections. So, and then you have to always look at the cause and treat the cause. Okay. So if there's a recirculation, see adjust the cannula position, they might be very close to each other. In case of VA ECMO, if both the tube colors are bright, there's no recirculation in VA ECMO. In that means either both the cannulas are in the artery, or both the cannulas are being connected wrongly. So the drainage tube is connected to the artery, and the return tube is connected to the vein. So in that case, we will receive both the tubular And then you have to see the connections and you have to correct the connections and uh, look at the sweep gauge. If this has not been connected, connect the sweep gauge. Or there can be a problem with the blender, so change the blender if required. What you can do is easy is you can take the pipe out from the blender and connect it to the oxygen cylinder and see what happens. If the color change takes place immediately, that means your blender is malfunctioning. Okay. The second problem you will see the moment you start is can be a severe hypotension. Now, transient hypotension and bradycardia you always see when you start with the patient on VV ECMO, but that transient remains for few seconds to a minute or two, not more than that. Okay, that's okay. But if it is remaining persistent, you have to think about there might be something wrong. So you have to think if it is a VA ECMO and the BP drops suddenly, it means your connection is wrong. You are draining from the artery and returning to the vein, and that's why your pressure has not improved. Or there is a possibility that patient has bled inside, and the commonest site of bleeding is going to be retroperitoneal bleed, or there can be a cardiac tamponade. So you have to diagnose and treat it. The third problem you see is the CO2 is persistently rising. Okay. Again, the CO2 should not rise. If it is rising, that means there's something wrong with your blender or there's somewhere leak in the sweep gas line. So even if you kept the sweep gas of 4 liters, it is not going 4 liters because there's a leak somewhere. So it is going actually 2 liters or 1 liter only that much. And that's why the CO2 is rising. There can be a cardiac stunning that can occur only if you go rapidly on the flow. So, and for that, you have to go slowly up on the flow so that you don't get the cardiac stunning. Okay. Or there can be a neurological deterioration. Patient can develop IC bleed or cerebral edema. And that is why I said prevent reperfusion injury. Go slow on saturation, go slow on CO2. Especially the CO2 correction should be very, very slowly done. So your aim is, one of the goal is to achieve adequate support. Okay. So your support should be adequate. Now, how will you get adequate support? You can get adequate support by an optimal flow. So I'm talking about optimal flow. I'm not talking about adequate flow. So you should try to get an optimal flow to get an adequate support. So you can go up on the volume. If you are not getting enough flow, you can give fluids and get the volume up, and then you might get the flow. You see to it that your cannula size is big enough to support your flow, how much the flow you require. If that is not helping, then you might have to put an additional cannula. So put additional cannula if you required. Okay. If your flow is not able to achieve the adequate support, in that thing, you have to think about ancillary support, other support which can which can make the patient adequate support. So you have to think about manipulating the metabolic need. You might have to sedate the patient, treat fever, get the metabolic need down, sepsis, treat the sepsis, hypothermia. So you try to get the metabolic need down or demand down, and thereby you can increase the oxygenation or tissue perfusions. Maintain hematocrit. That is another way of improving the oxygen delivery. Set support from the organs. So we might go up on the ventilator to settings to some extent. Instead of 21 to 30% of FI2, go up to 60% of FI2. That is safe enough. So you can go up to 60% of FI2. You might start small dose of inotropes. Inotropic score less than 20 is going to be safe. So you might start that. To, if required, you can take the support from the disease organ also, but that is only is a later choice, not as a first choice, because our aim is to rest the organ. So what is important is balance the flow and ancillary support, which is safe. So you to always, as I showed you, you to always decide which is going to be safer to maintain the adequacy of flow. So there's a difference in adequate flow and an optimal flow. See, adequate flow means that the amount of flow you require to achieve the adequate support. So if you want to have saturation of 80, whatever the support flow is required, whether it is 5 liters or 6 liters or 7 liters or 8 liters, that is an adequate flow. But optimal flow is both adequate as well as safe flow. Okay. So optimal flow is the adequacy plus safety, okay, to achieve your goal. So optimal flow is the one which achieves your goal, which is adequate enough to meet the metabolic needs, as well as which is safe enough so that it does not cause harm to the patients. And that's why it is known as optimal flow, which is the balance of adequacy and safety. This I think I already discussed how we'll assess the adequacy of VA ECMO and VV ECMO. Go by tissue perfusions, urine output, mean arterial pressures, and inotropic support should be minimum. That shows the adequacy of the support. In VV ECMO, you look at the saturation, look at the pH, look at the PCO2 level, and that all things you are looking at with the rest ventilator settings, then it means it is an adequate support. How will you assess the safety? So in general, when any patient on ECMO, the safety is generated, is assessed by looking at the circuit pressures. Okay, looking at the flow, how much is the flow is. Okay, too high flow, if the flow is too high, you are unable to achieve, then there will be too much of negative pressures and then you may have hemolysis. Okay, so hemolysis that can occur even with the too high circuit pressures. So if you go on very high flow, okay, then your circuit pressures can become minus too much negative or too much positive, and that cause hemolysis. Okay, if the flow is too low, then it will be inadequate support and there is a tendency to clot formation. So safety in general, you have to think in terms of flow, which is too high or too low. Both are going to be dangerous. Safety in VV ECMO, again, if you go too high a flow, you will cause recirculation and RV stunning or RV dysfunction. If your flow is going to be less, then it is going to be hypoxia. Patient can develop tachypnea, ventilator. That is going to be a cycle. Once the patient develops hypoxia because your flow is low, he is going to try to get the air oxygenation from the ventilator, from the native lungs. And in that case, patient becomes tachypneic, he becomes asynchronous, and the risk of CD will increase. While safety in VA ECMO is if you are going too high flow, okay, it can give us a cardiac stunning and LV distension and a poor lung perfusion. If the flow is too less, it will cause inadequate tissue perfusion, which can lead to multi-organ failure and neurological issues. So you have to be mindful about assessing about the safety of the flow. So monitoring for the optimal flow, how will you monitor optimal flow is, what will be the circuit related monitoring? Look at the circuit pressures and RPM and flow ratio. And look at any signs of hemolysis in terms of LDH, bilirubin, heptoglobin, plasma hemoglobin, urine, circuit-induced DIC. Patient-related in VV ECMO, look at the, for the optimal flow, look at the saturation, urine output, cardiac output, tachycardia, hypertension, neurological issues. So all that factors you have to see. Okay. And investigation-wise, look at the lactate levels, recirculation fractions, and hematocrit. By patient-related monitoring for VA ECMO, as I told you, look at the tissue perfusion, urine output, neurological status, pulse pressure, worsening the lung compliance. Investigation is going to be lactate levels, X-ray, and echo to see cardiac stunning, and X-ray to see pulmonary edema. Okay. So this is, I think I already discussed about this yesterday, safety and efficacy of the circuit, how will you monitor safety and efficacy of the therapy and safety of the patient in general. So when you have to manage this patient on ECMO, there are two components of management. One is you have to manage the ECMO and its physiology so that does not become harmful to the patient. And second is managing the patient so you can come off the ECMO as early as possible. The organ recovers and you can come off the ECMO as early as possible. So the management of ECMO, basically, I divide into three parts. One is the management of ECMO per se for an adequate and safe support, and that is what I discussed. Maintain the blood gas, maintain anticoagulation, avoid any complications for VV as well as VA ECMO. Management of organ, so give rest to the organs, but at the same time, try further damage to the organs and try to help do something that can help to recover the organ. Okay, so you have to adjust your ventilator setting, you have to adjust your inotropic requirements, you have to do some ancillary measures to improve the lung functions faster, and in case of VA ECMO, think about maintaining the good pulsatility so that heart recovers fast. Okay, and in general management to maintain other organ functions and a good nursing care, and that becomes the three parts of management of patients on any patient on ECMO. So this is just an example. If I see a PO2 of more than 50, if the saturation is more than 85, that's an adequate, and we are happy with that. But sometimes we don't get PO2 more than 40, your saturation remains 70, 75. Will you accept it? But in that scenario, you observe whether the patient is sensorium, how is the sensorium, how is the hemodynamics, how is the urine output, how is lactates. If everything is fine, you can still accept it. So that's an adequacy of the support. Really, because you don't want to cross the safety limit. If you go beyond this, the safety will come at cross. So if you observe this and that everything is fine, you can just continue. If you feel that, this is lactates are going up, urine output is going down, hemodynamic patient is becoming unstable, or patient sensorium is going down, is becoming drowsy, then guys, you need to treat it. So again, as I told you, there are multiple options how to treat it. You can go up on the ECMO settings, go up on the flow, go up on the FiO2. You can increase the oxygen delivery by going up on the hematocrit. So give blood and get the hematocrit. Decrease the requirements. You make the patient sedated, deeply sedated, make the patient cold. If there's a sepsis, treat the sepsis. Or you can increase the ventilator settings. Okay. You can go up to, again, you have to go up to the safe margin. So go on FiO2 of 60. Okay. And if the PCO2 is going to create problem, increase the sweep gas. And then we have to find out what is the cause, why the patient is not getting adequately supported, and treat this patient. So that's about the blood gas management. How will you do blood gas management? Fluid management, fluid restrictions in most of the cases we always say, and that is also we intend to practice. But in first 24 to 48 hours, that may not be possible. Okay, because the patient is fluid depleted, most of the times in the ARDS we practice dry lung strategy. Okay, so we may not be getting good flow, or patient because of some surge reaction, patient is going into fluid is going to third space, and you might require to give lot of fluids, or patient is on high ECMO flow, so you might require to give fluid, or patient is bleeding somewhere, or patient has got diuretic because of it was an hypoxic kidney, and once kidney gets good blood supply, patient can go into diuretic phase. So you have to think about assessment of fluid status. So how will you assess the fluid status? In VA ECMO is going to be very difficult. The only thing is that probably help is just fluid challenge, and that might help in VA ECMO. Even pulmonary artery pressure is going to be difficult giving you an answer. Pre-pump pressures definitely that can tell you, but most of the monitor has got limitation that it cannot sense the pre-pump pressures more than -40. So that is the limitations everywhere. As I told you, the only thing which helps you is response to the fluid challenge or stroke volume variation, but that is only possible in case of VB ECMO, not in VA ECMO. And try to maintain the daily requirement of the fluids. Hemodynamic managements try to maintain the mean artery pressure in 17 in adult patients, in pediatrics are around 50 to 60, and neonates around 40 to 60, depend on the age of the patient. Reduce in VECMO, you can get down on the inotrope faster, but again, don't directly shut down the inotrope. That is what usually people do in cardiopulmonary bypass. That is because that heart is normal heart. This heart is not normal. So you don't come down on the supports immediately without anything. Get the inotropes down gradually. You might come down within an hour or 2 hours, but don't stop it abruptly. Okay. Most of the patients still do require some amount of inotropic supports. Might be inotropic score might be 5 or 6 or 10, but they do require some amount of support, both VA as well as VV ECMO. In VA ECMO to maintain the pulsatility, and in VV ECMO to maintain the cardiac support or output. So that is what is usually required. Most of the patients, they do develop hypertensive response. That's the common thing, then hypertensive response. And that is because in VV ECMO, because we are improving the oxygenation, in VA ECMO also we are improving the, you are unloading the heart. So they can develop hypertensive response. Plus, when the patient is on ECMO, your ECMO circuits absorb most of the sedation, so that the sedative effect also goes away. So they can develop hypertension response. Then in that case, you have to sedate the patients or use antihypertensive, either NTG or labetalol or esmolol. Okay, these are the three which we use more often. If the heart rate is high, BP is high, usually prefer to use labetalol versus esmolol. Okay, NTG, if the heart rate is okay, we prefer to use NTG. Then I think Vivek has very clearly said about the ventilator management, what should be your ventilator setting. As Vivek said, what is most important is give rest to the lungs. Let the lungs to open clearly, gently, and lungs to heal. So you have to just go by ultra-protective ventilation strategy. Do not try to recruit the lung every day if the lung is not in a position. Okay, if the lungs are white like this, there's no point in recruiting the lungs because you are not helping the lungs, but on the contrary, you might worsen the normal part of the lungs. Okay, so usually we follow a rest ventilator settings both in VA ECMO and VV ECMO. VA ECMO, we are not very stringent because lungs are not that diseased, but in VV ECMO we follow stringently the rest ventilator settings, and usually it's a rule of 10, 10, 10. Get the FR to less than 40, respirator around 8 to 10 or maximum 12, peak pressure restricted to less than 25, and PEEP of 10 to 12. This is what we usually follow in our ICU. In VA ECMO, if the patient is at the time of initiation, the patient is not on ventilation, we don't put the patient on ventilator. But if the patient has pulmonary edema, and then we put the patient on ventilator, we try to keep the PEEP little on higher side so that pulmonary edema gets settled. In VV ECMO, first 48 hours, we try to sedate the patients and keep the patients. We get the PEEP down gradually. If the patient is on PEEP of 16, 18, we don't make it 10 immediately. We take 48 hours at least to get it down to 10 to 12. If the lungs are absolutely wide, there's no tidal getting generated, we try to like to prone these patients. If there is evidence of barotrauma, definitely we come down on the pressures to less than 20 and PEEP is titrated as per the patient tolerates. After initial phase of stabilization is over, we usually don't ventilate the patients in case of VA ECMO unless there's some issue with the lungs. Or in case of VV ECMO, we try to reduce the sedation, we make the patient awake, we take them on a spontaneous mode of ventilation like pressure support. If RR is acceptable, since respirator is less than 30, if the CO2 is, then we think of keeping this patient awake, and then we take a call whether to extubate this patient or no. If RR is high, then we try to get the CO2 less than 30 by adjusting the sweep gas, and that can decrease the respiratory drive and you can control the respiratory rate. If that is still not happening, then probably we don't think of extubating the patient, or if patient is already extubated, we plan to re-intubate this patient, and then we think about why it has happened and evaluate to go then treat it. Okay. There are certain exceptional stretches where you might have to go a little high on the ventilator settings, like in case of pulmonary hemorrhage, capillary coronary hypoxia, and in case of differential hypoxia. So you might have to go up a bit on the ventilator settings. In pulmonary hemorrhage, we prefer to go on a bi-level ventilator or APRV mode so that we can decrease the risk of bleeding, pulmonary hemorrhage. Anticoagulation, there's a separate talk on anticoagulation, so I'm not going in depth of it. But then we target ACT of 160 to 180 in VV ECMO and 180 to 200 in VA and VAV ECMO. Most of the time we use a fractionated heparin, but sometimes we might have to use bivalvuridine. But always keep in mind, heparin is more towards the bleeding, while the bivalvuridine is more towards the tendency to thrombotic formation. Bivalvuridine should need to be used if there's a triglycerides are high. One should not use bivalvuridine. At the same time, if there's a slow flow, or whether there's when there's a cardiac stunning, you should not use bivalvuridine because that will increase the risk of thrombus formation. APTT versus ACT. Definitely ACT is more convenient to do, but APTT is more reliable. So you have to balance both. Advanced monitoring like TAG, ROTEM should be done if the patient is bleeding somewhere. What is more important is combination of the TENS are important, and new circuits are in research which can become more biocompatible. I think that is going to be discussed in detail. Sedation issues, we prefer to get the sedations down after 48 hours, try to make the patient awake. No muscle relaxation, relaxation to be used, especially when you are trying to wean the patient from the ECMO, so that time don't use it at all. Propofol, lipid, or any drug which is lipid based can affect the oxidative functions. However, it is found that in PMP oxidative is not affecting much, but it still can affect. So usually we try to avoid it, but it's not an absolute contraindication like it was previous papers. If you see, they say it's an absolute contraindication, but now it is not an absolute contraindication. Okay. Transfusion strategies, I think triggers I already discussed today in the morning when I talk about the revision of the recap lecture. So these are the thresholds and transfusion triggers which we follow. Antibodies, that's the most important thing. And this is very important because
One is it will accelerate your cost. Number two, you might require support for a longer time, so you will require antibiotics in future. So that is what is most important is your ec- for ECMO sake, you require only antibiotics for 3 doses of antibiotics. You don't require more than that if you are able to take care of effectively. Now, suppose the patient, you are putting a patient of cardiogenic shock on ECMO. You may not require, if there's no chance of infection, you may not require to put the patient on antibiotics for a longer period of time. Okay. If there's viral infections, again, you don't require to put the patient on antibiotics. So always try to de-escalate if you are sure about it, that antibiotic is not required, and keep a low threshold of coming up on the antibiotics. Restart the antibiotics or go escalating the antibiotics. You can keep the low threshold, but the moment you find that uh, there's no evidence of infection, you should think about de-escalating the antibiotics. You have to maintain good nutrition. Usually they are these patients are sick. They are in a say excessive catabolic state. So they plus there's a lot of adsorption of proteins in the circuit. So they develop hyperproteinemia, and that can create problems. So you have to maintain good calorie, high protein diet. You have to start with 1 gram per kg per day and then gradually go up to 1.5. In the patient toilets, you can even go up to 2 gram per kg per day. But again, that depends whether the patient is tolerating it or not. But at least 1 gram per kg per day should be given. Supplement the trace element, especially this is true when the patient is on VV ECMO for a long time, for 3 to 4 weeks or more than that. You have to think about it. TPN, again, anything lipid based, we try to avoid it, but if it's mandatory, you can still give it, but that is only when the patient is not tolerating enteral feeds. All kind of general nursing care is possible and you should do it. There's nothing that you have to get yourself that, this patient is on ECMO, so we can't do chest physiotherapy, you can't do suction, or we can't do positioning. No, everything you can do it, but you have to do everything with an extra care so that your suction trauma does not cause bleeding. Do not do change of line as a routine. Okay. Change of catheter as a routine, especially change of Riles tube, please. So that times are not required. Only thing is then when we feel that yes, there's an infection, the fever, we might that time you change, that's okay, but not as a routine. Okay, 7 days ho gaya to change karo. That should not be the attitude. Okay. But whatever you are doing, you have to follow a safety precautions. And what are the safety precautions? Is secure cannula properly, especially the neck cannula, because that is the one which can come out. The return cannula is the one which is only 15 centimeters side. So there are risks that that cannula can come out. So you have to hold that cannula properly whenever you do anything with the patients. Look at the RPM and flow ratio, whether they are maintained same. With the same RPM, the flow decreases. You have to think either the preload has decreased or the upload has increased, and look for the cause, look for the kinking, take care of all connections, and look for the recirculation and desaturation. Yeah. You can even ambulate the patients. You can make the patient sit and move around also. That also can be done. But for that, you have to do a screening. You have to do medical screening first, whether the patient is fit enough for mobilization. Okay. Look at a physical assessment, whether the patient has got enough power that he can be mobilized. Look at the functional assessment by making them bedside activities, making them sitting, standing. Okay. And then you make the patient to move around. And if a patient fails to any of this, uh, screening, don't do mobilization, wait for 24 hours and reassess after 24 hours. Management of complications, I think there will be a separate talk on this, so I'm not, already there's a separate talk on VV ECMO and VA ECMO, so I'm not going to talk about this. So management of VV ECMO complications like recirculation, pulmonary hemorrhage, and right heart failure that you have to manage. Management of VA ECMO, that's cardiac stunning, there is a separate lecture for that tomorrow. Management of referential hypoxia and management of liver ischemia, that you have to do it. Okay. Finally, for a VV ECMO, as I told you, inotropic score is support is not a contraindication. Maintain good venous pressure so that you get good flow. Always be aware about recirculation. If hypoxia is there, if the drainage is not proper, put an additional drainage cannula, make it VVV. Control cardiac output if the patient is becoming goes into hypermetabolic state. If required to use hypothermia, maintain hematocrit, give rest to the lungs. VA ECMO, always give partial support. Don't go full support. Give only 50 to 75% of the total cardiac output support. Please look at the pulse pressure and maintain the pulse pressure more than 10. Flow titration as per the tissue perfusions. Don't get carried away only by the mean artery pressure. Go by tissue perfusion. Do not forget the distal perfusion cannulas. Always keep that in mind. Don't let the flow directed towards the aortic valve because that can damage the aortic valve. And in case if you find there's a differential hypoxia, you might have to go up on the ventilator settings. If that is not helping, then switch over to VAV ECMO. Management of cardiac stunning. Again, I'm going to discuss this in tomorrow as a separate lecture, so I'm not discussing it right now. But the importance is give rest to the heart. So to run an ECMO, in successful ECMO, you require a right team, right time, right candidate, smooth cannulation, and smooth initiation at the time of initiation. ECMO runs should do with the support adequately and safely. This is the most important word. It's not adequately or safely. It's going to be adequately and safely. Be ahead of the disease. That is the most important. You should always be ahead of the disease. If you chase the disease, you will never succeed. You have to be ahead of the disease. You should know what complications can come and you are being prepared for that. Give rest to the lungs, but don't make it lazy. Okay. So don't just let lungs remain like that. You are not giving any PEEP, you are not giving any physiotherapy, you are not mobilizing the patient, not turning the patients. That is not going to help you. That is going to delay the lung recovery. That is going to delay the heart recovery. And that in number of the ECMO days, as it increases, it will increase the risk of complications. Avoid unnecessary interventions. You to always weigh high risk versus the benefits of doing whatever intervention you are going to do, any surgical procedures. Minimize the cost, spare antibiotics, aseptic precaution, and keep patients and be persistent. That is the thing you should do when the patient is ECMO run. And whenever you get in time of when window of opportunity, try to win the patients of ECMO. Don't just say that, okay, today is Saturday night. We don't want to win this patient today because there will be nobody in the Sunday, and don't unnecessarily extend it. Whenever you get a window of opportunity, try to win the patient and get the patient out. So for a successful ECMO, you require a well-organized team, a well-experienced and receptive team leader. That is very important. You should have a receptive team leader who can be ECMO or clinical leaders, anybody. But then he has to be receptive and well-experienced. Okay. So I want that from when you go from this training course, you let the ECMO become a gymnastic of perfect control and not just the game of dice. Bach gaya to bach gaya. If person survives, fine. Otherwise, he was sick only. I don't want that things to. So the last word is keep patients, keep patient alive and do not harm. Thank you.